Welcome to my presentation about the 2013-2015 Ebola virus outbreaks. I'll preface this presentation by saying that in elementary school, we had to do presentations about what we wanted to be when we grew up. Some of my classmates wanted to be lawyers or doctors or rappers or actresses. I explained to the class that I wanted to be a virologist and study Ebola in the Congo. I bet that was the first time my teacher had ever heard that one. Later in life, I realized that Ebola is really cool. But since Ebola outbreaks are few and far between, studying it wouldn't be as fun as I thought. Boy, was I disappointed with that decision in 2014 when this outbreak was at its peak. I could have been in really high demand. So let's take a look at this epidemic. I want to take you back to October 8th, 2014, when Thomas Eric Duncan passed away from Ebola virus. He was a Liberian citizen who became the first Ebola virus patient diagnosed in the United States on September 30th, 2014. Mr. Duncan was visiting family in Dallas from Liberia. Before leaving Monrovia, he helped transfer his landlord to an Ebola treatment ward. Mr. Duncan had lied on his screening questionnaire in Brussels before boarding the flight to the United States. He was treated at Texas Health Presbyterian Hospital in Dallas, where healthcare workers who cared for him also became infected with Ebola virus. Misadventures in public transportation plagued the U.S. Ebola virus response. Thomas's nurse, Amber Vinson, got on a plane to fly to Ohio and shop for wedding dresses after treating him. She tested positive soon after. There was public and media outrage about this chain of events. Many people blamed Vinson for getting on the plane when she knew she had been exposed to Ebola virus, but Vinson had asked her ICU managers if it was okay to travel, and she had also called the CDC to report that her temperature was 99.5 degrees. She had no other symptoms. Both her ICU managers and the CDC told her she was safe to fly. That initial Ebola virus exposure is also when we started to care more about this outbreak here in the United States. We saw that it really can make it to our country, and while it could make it here, Ebola never really had a chance to spread here in the United States. That's because while Ebola is an infectious disease, it's really more a socioeconomic disease than anything else. So, let's learn a little bit more about Ebola virus. It's most famous for causing Ebola hemorrhagic fever, as popularized by Richard Preston's The Hot Zone. Ebola virus is a single-strand negative sense RNA virus that belongs to the Filoviridae family of viruses. Filoviruses have nucleotide substitution rates approximately 100 times lower than other RNA viruses. That just means they don't mutate a whole lot or very quickly. There are 5 known strains. The 3 that we found that are harmful to humans are Zaire Ebola virus, that one's also called Ebola virus, Sudan Ebola virus, and Bundibugyo virus. Bundibugyo is the newest one. And the 2 that mostly affect non-human primates are Typhorus Ebola virus and Reston Ebola virus. Reston Ebola virus can transmit through the air, but it's not harmful to humans at all. Typhorus has seen a single human spillover infection when a chimp passed it to a vet who was doing a necropsy. The main animal reservoir is thought to be fruit bats. Ebola virus has an R0 of approximately 2. That means one person is likely to spread it to 2 others. It has a fatality rate of about 50% overall, depending on the country affected. Initial symptoms are usually fever, severe diarrhea, and vomiting. So they're kind of normal symptoms for especially around flu season. Unlike the flu, Ebola ultimately targets a wide range of cells and organs, including the liver, spleen, and adrenal glands. It causes a cytopathic effect, much like the cytokine storm we've been hearing so much about, which leads to shock and fatal end organ damage. There is bleeding involved, of course. It is, after all, a hemorrhagic fever. If you've read Richard Preston's book, you probably associate Ebola virus with bleeding out of the eyes and organs liquefying. The real disease isn't usually that graphic, but it is very severe. It looks more like sepsis or cytokine storm than it does a zombie movie. Some physicians believe that patients in developing countries end up dying from poor hydration. If you think about diseases like cholera, people usually die from the constant loss of fluids. Diseases like this are characterized by lots of diarrhea and vomiting. The same is true of Ebola virus. You tend to expel so much fluid, life-threatening dehydration is a major problem. In some of the countries affected, patients are more often treated at home than at the hospital. And even if they do make it to the hospital, they often don't have the space or time at the hospital to supply constant fluids and monitor the patient's electrolytes. There is some contention that it's probably sepsis that people die from, but either way, your patients aren't spewing blood out of their orifices. They are spewing a lot of virus, though. Ebola virus is carried in bodily fluids, but not in respiratory particles. It's not airborne. It's transmitted through mucosal surfaces and breached skin. Ebola virus is shed in a broad range of fluids, including blood, stool, urine, sweat, vaginal secretions, amniotic fluid, saliva, tears, aqueous humor, cerebral spinal fluid, breast milk, and semen. Blood, however, is among the most infectious of fluids. The major mode of transmission is direct contact with infected fluids, especially blood. Interestingly enough, the highest levels of virus are usually found at the time of death, and infectious virions can be found for up to 10 weeks after death. Touching dead bodies doubles the risk of infection. These patients don't shed virus until they're symptomatic. Ebola patients who are shedding virus are usually not up and walking around. They are very sick patients. Contact with infected people or cadavers is the number one way it's spread. Healthcare workers are disproportionately affected. They are at least 100 times more likely to be exposed to Ebola virus than the general population. Remember when I said before that Ebola virus was more of a socioeconomic disease than an infectious one? That's because of the characteristics of infection. Asymptomatic people don't spread it. You spread it more, symptoms become more obvious. Contact with bodily fluids and cadavers are the main way it's spread. Ebola is particularly deadly, but it's not particularly infectious. Sociological factors were behind these outbreaks. Prior to 2012, there were small clusters of Ebola virus outbreaks, but we had never seen the persistence of Ebola like in this epidemic. From 2013 to 2015, we had 28,646 cases and 11,323 fatalities. Prior to that, most of the outbreaks had been in the hundreds of cases. What was different? It wasn't the disease. The virus didn't change at all. The course of the disease didn't change. The treatments didn't change. It was sociological factors that were different in this outbreak. Ebola virus had never been in West Africa before. This time it mostly hit Guinea, Sierra Leone, and Liberia. The communities in that part of the world are very mobile. The borders are very loose. People commonly travel long distances. These countries are poor and densely populated. All of this is the perfect mix for any infectious disease to travel. However, the sociology of this region has some more specific things that make it perfect for Ebola virus in particular. Whereas we know that Ebola virus will never sustain those numbers here in the West. On March 10, 2014, the Ministry of Health in Guinea was alerted to an outbreak of a disease characterized by fever, severe diarrhea, vomiting, and a high fatality rate. A team from the Ministry of Health arrived on March 14th. They thought it was Lassa fever because Ebola virus had never been in that part of Africa before, but doctors on site found that 9 cases, 8 fatalities, were associated with a funeral. A team from Doctors Without Borders arrived on March 18th. Blood samples confirmed Ebola virus disease. The WHO announced the outbreak on March 23, 2014. Retrospectively, we think a 2-year-old child who got sick on December 2nd and died 4 days later in a village in southeastern Guinea was the index case. Other family members and villagers rapidly became unwell and died. You would think a small outbreak in a village would be easy to curb, but there are socioeconomic factors that made it a little bit harder. For one, that region has been showered with civil war and shady government dealings for decades. Guineans didn't trust the outsiders, but they didn't trust their government either. They thought healthcare workers were part of a conspiracy against them or were actually infecting them with Ebola virus. They thought cleaning crews might be actually spreading the virus instead of cleaning up. This type of mistrust is true of other countries in the region that were affected by this outbreak as well. Another major problem is the burial rites in that region are very complex and they involve lots of touching of the dead. It's traditional in many locations for people to travel long distances to participate in the bathing and readying of the dead for their journey. When guidelines were put into place by people like the WHO or the government, locals thought they were doing their dead a disservice by not partaking in a traditional funeral practice, and that their loved ones would be cursed for eternity. Funerals were often held in secret, and no one admitted to coming in contact with those infected. Another major problem is that the WHO waited to declare the outbreak a public health emergency of international concern, or a PHEC, on August 8th. Guinea witnessed 2,543 Ebola deaths and 3,811 cases. The first case in Liberia was on March 20th, 2014, 8 days after the first Guinea case. The Liberian government got more support than Guinea did at first. They formed a high-level national task force composed of the WHO, UNICEF, and international non-governmental organizations. The CDC from America also sent teams. However, they believed the outbreak was relatively small, There were only 13 cases that were reported at that point. So the CDC and the WHO withdrew support in June, despite concerns from Doctors Without Borders that there was unprecedented geographical spread and that there may be a major issue here. This later drew criticism. Hindsight is 2020. By the end of June in Liberia, there were 107 suspected Ebola cases and 65 deaths. In August, 2 American volunteers were infected, and Samaritan's Purse suspended operations in Liberia and evacuated. Doctors Without Borders took over, and the Liberian government closed most border points and most schools. Cases rose until October saw the greatest number of cases with 3,077 cases. In November, the U.S. proposed to send troops and aid, which resulted in building new Ebola treatment centers around the region, increased laboratory capacity, and increased air transport of supplies. There were new awareness programs put into effect. However, transmission had decreased before the Ebola treatment centers became operational, and many of them never treated a single patient. Only 28 Ebola patients were treated at the 11 treatment units built by the United States. 9 centers never saw a single patient. Similar to Guinea, there was also mistrust in Liberia during these outbreaks. In mid-August, residents tried to dismantle an Ebola screening point because they thought it was a risk to their safety. Fear of stigmatization led some people to hide symptoms to avoid contact tracing. The government made it illegal to conceal an Ebola-infected patient or exposure to Ebola, and that was punishable by prison time of 2 years. This furthered mistrust of testing. Why would anyone want to get tested if they then had to tell on their friends and family? Liberia had 10,678 cases and 4,810 deaths. The first case in Sierra Leone was on May 25, 2014. They had already begun an enhanced surveillance program because of the outbreaks in the other countries around them. By September, Ebola virus was in the densely populated capital of Sierra Leone, which caused the government to escalate the response. A state of emergency was declared and a 3-day national lockdown was imposed. Door-to-door campaigns to find the affected were initiated. Quarantine restrictions were put in place, curfews were instated, schools and public places were closed, and screening at borders was initiated. These acts were, of course, controversial. Imagine people you don't trust, maybe with guns, coming door to door to ask if you've been exposed or if you've broken curfew. There were food shortages that affected some areas of the region and forced people to break curfew or starve. Many healthcare workers thought these measures were extreme because asymptomatic people don't spread this disease. We had similar arguments when Ebola hit the United States. Even some prominent virologists were in disagreement about potential U.S. travel bans. More healthcare workers died in Sierra Leone than any other country. It's believed mostly due to the dense population and poor conditions at the hospitals. Frontline workers did strike because of the conditions and the pay. They were promised hazard pay that they never received. Sierra Leone had 14,124 cases and 3,956 deaths. So, what did we learn, and what didn't we learn, probably, judging by what's happened here in 2020? Models predicted that 28,000 cases and 11,000 deaths could have been prevented with stronger preparedness and faster response. After the SARS epidemic of 2003, there were major efforts to build surveillance and response systems to identify and respond to epidemics globally. They didn't work here. Ebola virus was identified in the 1970s, so why weren't we prepared? As with most things, the world didn't care about Ebola virus until it threatened the developed world. When it was just an African problem, it was a lot easier for us to ignore. We also learned that advanced planning is best. We need to build infrastructure. This epidemic happened in some of the poorest countries in the world that have been plagued with civil war for decades. They have poor transportation systems for patients, poor laboratory capacity. It would make sense to give them some money to help build those up instead of waiting until they need it. SARS and Ebola both warned us that we are a global community and the weakest links can affect us all. Millions of dollars and thousands of lives could be saved by planning for such outbreaks before they occur. One of the big fails was building the Ebola treatment centers in Liberia. Some of them were never used, but even if they had been, building them in the middle of an epidemic is costly and it makes very little sense. In this case, the epidemic was already waning before they were opened. Critics contend that had the Americans and other donors been more flexible, the money could have been put towards rebuilding Liberia's shattered healthcare system instead of building these temporary centers. For one thing, it takes a long time to learn proper donning and doffing procedures for PPE. And donning and doffing is when you take off and put on the personal protective equipment. Proper infection control and getting enough staff members to man these places also takes time. In the peak of this epidemic, workers were exhausted. I know Doctors Without Borders has someone who specifically watches people doff and don to make sure they don't miss a step, because it's very easy to miss one when you're tired, and one mistake can cost you your life. It's hard to imagine you'll get that kind of expertise or even the staff members to do that in the middle of an epidemic. Funding for rapid and accurate testing is important too. Testing was slow during this outbreak. Does that sound familiar? In one case, a taxi driver brought a sick woman to the hospital. 10 days later, he had a stroke and was himself put in the hospital. He was discharged and sent back to his village to be tested for Ebola virus. He died several days later, and his body was there for 3 days before his test results came back. Because he had been discharged from the hospital, the village thought he hadn't died from Ebola virus, but from the stroke. The subsequent outbreak killed more than 40 people. Had he been tested quickly, they may have used precautions. There's at least one approved rapid antigen test now, and several rapid molecular tests were field tested during a 2018 Ebola virus outbreak in the DRC. Coincidentally, that outbreak was stopped quickly. Prior to Ebola reaching Western shores, there wasn't much money available to research these rapid antigen tests or vaccines. Lack of infrastructure doesn't only impair testing for Ebola virus, there's also a high mortality rate due to lack of follow-up. Some people who are discharged recovered from Ebola virus end up with long-term organ damage and die from lack of follow-up care. Sociological factors have a major impact on these epidemics. The WHO coming in with guidelines doesn't make it any easier to change societal norms. We've seen that here with masking and coronavirus. What they found worked the best was consulting with local religious authorities and community leaders to find things that worked for both parties. For example, instead of shrouding bodies with white cloth, they recommended the use of white body bags. Religious leaders championed personal protective equipment at burials and presented evidence that praying at absentia was sufficient to help your loved one in the afterlife. You have to bring people in the community together with someone the community trusts to get everyone on board with these guidelines. Another familiar controversy is quarantines and travel bans. So for Ebola virus, we found they mostly didn't work. They mostly dissuaded people from volunteering to help. So especially those people who would have had to travel to West Africa to help, they didn't want to travel there and then be stuck there for months. And they made very little sense due to the mode of transmission of Ebola virus. They also made people in the region more likely to lie or hide their illness because they didn't want to be quarantined. So here in the U.S., we had prominent political figures, the public, and virologists who were all disagreeing about travel bans back and forth. Mostly healthcare practitioners thought that it didn't make sense for a virus that spread via symptomatic fluid transfer. Bans to and from countries also prevented affected countries from receiving medical supplies, food, and that sort of thing as well. So it was pretty controversial. Another thing we should have learned, but probably didn't, is that the healthcare workforce needs to be respected and protected. During this epidemic, the healthcare workforce was not adequately paid or staffed, and many didn't have proper personal protective equipment. That not only affected their response to the Ebola virus epidemic, but it also affected their ability to do future work. Workers were promised hazard pay they never received. I've been reading articles about the region's COVID response, and many healthcare workers are staying home. An ambulance driver at the Kinema Government Hospital in Sierra Leone said, "Since they never paid us what they owed us during Ebola, I've decided not to risk my life again for COVID." Our response wasn't all bad, though. We actually did learn some things that we've applied here in 2020 for our SARS-CoV-2 pandemic. This was the first time red tape was cut so we could have expedited vaccine trials, and we've seen that again here in 2020. Manufacturers collaborated and shared data like never before during this outbreak of Ebola virus. And again, with SARS-CoV-2, we've seen even more of that collaboration and sharing. Social science and biomedical efforts were mobilized so quickly and effectively during this Ebola virus outbreak. We had real-time genome sequencing. We could track the virus like never before. We've also seen that with SARS-CoV-2, we've even come further with tracking viruses here. So we did learn a few good things during the Ebola virus outbreak that we have applied here for our coronavirus. So while the Ebola treatment centers were a real fail for the Ebola virus response, they actually did teach us a little bit about treating and assessing people off-site for disease surges. So that's come in handy for the peak of SARS-CoV-2 as well. This Ebola virus outbreak is actually what prompted the WHO to launch the Joint External Evaluation Tool, which is a tool that helps assess national capacities to address public health threats. It's a voluntary, collaborative, multi-sectoral process to assess country capacities to prevent, detect, and rapidly respond to public health risks. So basically, it just helps countries identify the most critical gaps in preparedness and response. Africa also launched the African Center for Disease Control and Prevention because of this outbreak. This outbreak also prompted the establishment of the World Bank's Pandemic Emergence Financing Facility, and it was established to provide surge funding to prevent rare, high-severity disease from becoming pandemics. As of July 27, 2020, $146.5 million from this fund has been transferred to 48 countries. These funds help provide additional financial support to their COVID-19 response, and that includes purchasing essential and critical life-saving medical equipment and personal protective equipment for these countries. The United States created what was supposed to be a permanent unit inside of the National Security Council in response to these Ebola virus outbreaks. The office was mainly charged with coordinating responses to emerging infections. Obama's Ebola czar was not a healthcare worker, which came under scrutiny at the time. But what's really needed for emerging infections is someone to monitor the situation, raise alarms, coordinate between different government groups, and act as a go-between with other countries affected. We need someone to help resolve bureaucratic disputes and open up gridlocks. That person doesn't have to be an MD. They need to be more of a project manager. Unfortunately, in 2018, John Bolton took over that office and abolished it because he thought fighting pandemics is not a national security issue. In summary, while Ebola is an infectious disease, it's really a socio-economic disease. Panic swept U.S. hospitals and media when we were threatened with it, but epidemiologists were never really concerned about widespread cases here because the United States has healthcare infrastructure and different social and religious practices than the main population affected. However, the lessons we learned during Ebola were mostly soon forgotten, as evidenced by the SARS-CoV-2 epidemic. So, class, what further things should we have learned from the Ebola virus epidemic that I didn't mention? Are there any more comparisons we can make to the coronavirus epidemic, or maybe some contrast? And remembering that Ebola is an infectious disease, but it's really a socioeconomic disease, do you think a vaccine would stop further epidemics, or do you think the research on the vaccines should be directed somewhere else? Thank you.